May I introduce Mr. Hilali Noordeen, who has been a long-standing advisor on our special advisory panel. And bless his heart, he answers all the questions we send to him. So today he's going to bring us up to date about care of the spine at all ages. Our problem nowadays, it's a very nice problem, is that the average length of the life of a Marfan patient has risen during my lifetime from 32 years to 68 years. Now, I've had patients tell me that although they had a curve in the spine in youth, nobody operated because they didn't think they would live long enough. And now, of course, the older Marfan patient is having trouble with their back, with scoliosis, kyphosis. So this is, in a way, a nice problem because it's a problem of survival. But we'd also like Mr. Noordeen to help us explain how to care for the older patient as well as the younger patient. Mr. Noordeen was appointed consultant orthopedic and spinal surgeon at the Royal National Orthopaedic Hospital and Great Ormond Street Children's Hospital in 1995, as well as the Hospital for Neurology and Neurosurgery, Queen Square. He is a professor in spinal surgery and a very important member of our specialist advisory committee. Mr. Noordeen, can you update us, please?
Thank you very much. So just to thank my fellow Mr. Ali and at the Royal National Orthopaedic Hospital, and also I've got an elective student with me who's very much enjoyed working on this project because he's updated himself both on Marfans, but also about scoliosis on Marfans. So thanks to both of them. The problem, in a sense, is that approximately 70% of MFS patients have scoliosis of some degree. There's an equal sex preference. And what is very interesting is that the cervical spine is almost always normal. I haven't seen a single case or case report of a patient with a cervical spinal deformity. And the pathology is such. So if you can go straight to the third slide, please. So the pathology is such that there's a frequent progression during adolescence and curves are generally rigid. Next slide, please. I mean, in Marfans, the curve patterns don't really follow any particular pattern. Half the curves are atypical, to all the classifications that we've got. So, I mean, that's really not of particular value. The only questions, and again, next slide, please. I just give you, for example, the classification that I use for adolescent deformity. And what I can say is that half the patients do follow an adolescent type of scoliosis pattern, but half don't. The important thing, ultimately, next slide, please. And these are just some examples of some atypical curves. Are firstly that these curves are painful and progressive. They can cause respiratory problems, particularly in the very, very young patients. The curve progression is quite significant, particularly during adolescence, 7 to 10 degrees per year. Progression is more likely with curves greater than 20 degrees. Sorry, next slide, please. Progression is more likely with curves greater than 20 degrees in growing patients. And the most rapid increase occurs during early adolescence. This is where the biggest growth spurt occurs. Now, the predictive factors for progression to a severe deformity are basically, next slide, effectively female patients and a positive risk sign. And that was published by Taniguchi et al. In Spine recently in 2021. And that's looking at the demographic data for scoliosis in MFS patients. Next slide, please. And then the next. So conservative management, scoliosis, basically conservative treatment in MFS is generally ineffective. Bracing is complicated by the thoracic lordosis. You can't permanently straighten the curve with a brace Once removed, the spine will gradually return to its original curvature. Brace can be recommended for small curves, that is curves between 25 to 40 degrees, but something like a Milwaukee, a very rigid brace, would be indicated. But overall, the success of brace treatment is reported to be around 17%. Next slide, please. Then the next slide, please. So effectively, most patients with MFS will have significant curve progression that warrants surgical intervention. And normally what I like to do is to take this at approximately mid-puberty, when the curves are small, 40 to 50 degrees. Even though they have abnormal sagittal curvatures, those can be attended to as part of the surgery. And normally you can get away with doing a posterior spinal fusion with instrumentation, with autogenous bone grafting. And this, I'm happy to say, is the mainstay of treatment in the vast majority of patients. In the very young patients, next slide, please. Yeah, I mean, this is an example of it. Yeah, keep going. Next slide. Yeah, next slide, please. In the very young patients, we can use growing systems like the magic rod. It has been, then hasn't been, then has been, then hasn't been, and so on, approved by the MHRA. It certainly works absolutely fine in my hand. I've done reviews of my experience with the magic rods. Next slide, please. I've also looked at the most recent fears raised by the titanium levels and so on, and the answer is there isn't a problem in my practice. And again, I've looked at these. Next slide, please. My whole series over a period of, I've been using it now for about 10 years. Again, it seems to, the conclusion is it works fine in my hands. Next slide, please. Usually the recovery is pretty quick in the adolescent patients. 6 weeks light exercise, 3 months to back to full activity, 4 to 6 weeks off school. I follow my patients up for at least 2 years, or at least until skeletal maturity, initially at 6 weeks, then at 3 months, 6 months, 1 year, and finally at 2 years. Next slide, please. Well, of course, the complications seem awful, but they're actually quite small. Dural tears, splenic rupture, cardiovascular decompensation and failure, wound infection and wound healing, I guess, is probably the highest risk. All the others are so tiny. And in my lifetime of treating these patients, I haven't had either dural tears, splenic rupture, or any cardiovascular decompensation. Slightly more extensive blood loss during surgery, instrument complications, just like in any scoliosis surgery, recurrence of deformity or truncal imbalance, and then reoperation. Again, in my hands, quite low, I would say in the order of about 4 to 5%. Next slide, please. Now I've talked about the adolescent patients. I want to now talk about the problem that you want me to talk about, one of the problems you want me to talk about, which is what do we do with the older patient? And I just present a case study to you. Again, a patient who has a progression of deformity, increased pain during long walks, reduced function. But with as you get older, you also have an increased list of problems: dilated left ventricle, impaired systolic function, dilated left atrium, impaired right ventricular systolic function, restrictive ventilatory defect with limitations on walking, spinal deformity since childhood, progressive. So that's the sort of problem one would be served with as patients grow older. And of course, I mean, from a technical point of view, from a surgical point of view, sorry, next slide, please. From the next surgical point of view, I can correct the deformity. That's not the issue, but it's to really get my intensivist and anesthetist round to actually undertaking the operation, and also the hospital to accept the potential risks in these patients, because as I say, these are not common. They're only now beginning to come into the system of patients who actually want correction of their deformity. So obviously a full cardiac workup, echo, ECG, full respiratory assessment, and a pre-operative assessment where they're seen by our orthotists, by our anesthetists, intensivists, and so on. And then, of course, if everybody is in agreement, surgical intervention to correct the deformity using techniques that I've been using for many, many years. But effectively, in terms of the pain, the surgery is unlikely to improve the pain. And in fact, there's a 5% chance of increasing the pain. The problem, the surgery, the indication for surgery is simply to correct deformity and to prevent further progression of the deformity. Next slide, please. So, and then the final slide. So that's really an overview of the current status in scoliosis surgery, and obviously the most challenging part of it will be the older patients who, having survived in a way as they would not have done at the start of my and Anne's career, are now presenting with deformity and asking me the question what I plan to do about it. There were some questions as well that have been sent to me. Firstly, as I said in my talk, any degenerative deformity or any degenerative pain that occurs in the spine, particularly in the neck, is completely unrelated to the scoliosis and should be treated on its own merits. I think that was one of the questions. The second question was when would it be reasonable to operate on a patient, particularly an adolescent? And the answer is, well, as early as possible. Really, during mid-puberty is the best because they seem to recover from it best. And then a related question to that is if the patient has also got other comorbidities with it, including potential cognitive function and so on, is it really a reasonable option to undertake surgery? And I mean, look, I don't think there's one rule that is sufficient to all. I think the best thing to do is to have a preoperative assessment and then to have a detailed discussion with the whole surgical team as to what the potential risks and benefits are. I think those are the main questions that were asked of me. And if there's anything further, then of course I'd be very happy to answer them now.
Can I just present two questions sent in by the patients, further questions? Thank you very much for that lovely overview. Is there an indication for surgery in more pronounced lordosis in adolescents or adults?
Actually, that's a very good question because, I have come across this. And in my whole career, I've done it twice. And that is when the lordosis is so severe that the GI surgeons get upset about it because they can feel the spine through the abdomen, as it were. And it certainly seems to be an impediment to their abdominal, to their GI function. And in the two patients in my 26-year career as a consultant that I've done that on, they've both actually improved from having the lordosis treated.
Excellent. Another question, a patient says, my scoliosis is in the lumbar area, and the patient understands that this is inoperable. How do you feel about that?
No, I disagree with that. I have many patients whose scoliosis is in the lumbar area who I operate on, whether with Marfans or not. Right.
I understand that the fusion actually limits forward flexion. Can they still do up their shoelaces?
The thing is that Marfan's patients have hypermobility.
Yes.
And I mean, unless you do a long fusion all the way from T2 to pelvis, then that would be an unreasonable thing to do, and it would limit them. But if it is only in their lumbar spine, Yes, you would reduce their flexibility by 50% if you went below L5. In other words, if you included L5 and S1 and included the pelvis, but you very rarely have to do so in this day and age.
And one last question. For mild scoliosis, are there any recommended exercises that can help prevent progression?
I'm afraid we've looked at this. I mean, there are organizations out there who make the claim that there are exercise treatments that seem to correct scoliosis. I won't give you their names, but there are people who claim that, but I haven't seen. I know that in the States, they're undertaking a proper randomized control study on the value of exercise in scoliosis, but I haven't seen any studies that show it's of value.
Thank you for that. We have time for one or two more quick questions. Are there any in the audience? No, in that case, we'll say a very huge thank you, because I know it's been an upside down day for you. And we're very, very grateful that you've taken the time to help us out yet again and answer our questions and bring us all up to date. Certainly, it's very reassuring to hear that an older patient should be judged on their own merit, and they should still come and ask for an opinion.
Absolutely.
Yes. Thank you so much for answering.
Well, thank you, Anne, for asking me.